Morning everyone. So I'll be talking about the next topics, that is liver abscess, extrabiliary system, which includes PSC and PBC, and hepatocellular carcinoma, and also liver transplantation. Okay. So liver abscess, let's talk about pyogenic liver abscess. The most common causes of pyogenic liver abscess include cholangitis, mainly due to biliary obstruction. It could be hematogenous through the portal vein or hepatic artery, direct extension and traumas, any procedures by penetrating or non-penetrating, and an infection of the liver tumor or the cyst. So, what are the organisms causing pyogenic liver abscess? You have gram-negative aerobic bacteria, which includes E. coli, Klebsiella pneumonia, Enterobacter, Pseudomonas, Citrobacter, Morganella, Proteus, Salmonella. So, all these are the gram-negative aerobic bacteria. Gram-positive includes Enterococci and Streptococci, and Staph aureus, Streptococcus, Listeria, Bacillus. Anaerobic bacteria includes bacteroids, Fusobacterium, Streptococcus, Streptococcus, Clostridium, Actinomyces. Others like Candida and Mycobacterium tuberculosis can also cause. So clinical features, most commonly patients present with abdominal pain, severe abdominal pain, and mainly on the right or epigastrium to the right hypochondrium, and with fever with chills, and patient may complain of weight loss and tender hepatomegaly. Patient complains of severe pain on palpation. So diagnosis, you can do a direct culture of the fluid, you can aspirate the fluid and do direct culture, send for blood culture sensitivity and USG abdomen. If not, then CT. Okay, USG is pretty good. USG abdomen shows typical pyogenic liver abscess. If it's not clear, you can go for CT. So how do you compare pyogenic and amoebic liver abscess? The more DD for the pyogenic liver abscess. So often the pyogenic liver abscess are multiple. Amoebic is always single, usually single. Location can be seen in either lobe of the liver, and amoebic is usually on the right hepatic lobe near the diaphragm. Presentation, pyogenic presents as subacute and amoebic presents as acute. So icterus jaundice can be seen more commonly in moderate in amoebic, whereas mild in the case of pyogenic. Diagnosis, you do a USG or CT with aspiration. Aspiration is absolutely contraindicated in the case of amoebic liver abscess. Okay. So treatment, you do drainage and give IV antibiotics. Depending on the culture sensitivity, can step up. Whereas in amoebic liver abscess, you give metronidazole around 750 milligrams thrice daily, around for 7 to 10 days. So usually start with IV, then you shift to orals, or you can also give tinidazole, which is 2 grams orally for 3 days, which is followed by iodoquinol 650 milligrams 3 times daily for 20 days. So these two are more commonly given, metronidazole or tinidazole, which is then followed by iodoquinol. And diloxin daily for 10 days can also be given, and paromycin also 25 to 35 milligrams per kg per day orally in 3 devices thrice daily for 7 to 10 days. So this is a CT showing multiple pyogenic liver abscess. See multiple pyogenic liver abscess here. Okay, and this is a CT showing a large amoebic liver abscess, large single amoebic liver abscess. This is how pyogenic and amoebic liver abscess look like. Primary biliary cirrhosis, it is a chronic progressive cholestatic liver disease, mainly more commonly seen in middle-aged women, and it is a granulomatous inflammation of the portal tracts which causes loss of small and middle-sized bile ducts. And there is also fibrosis and cirrhosis of the liver in the later stages. Initial stages, you can only see the inflammation in the portal tracts, and then in the stage 3 and stage 4 you can see fibrosis and cirrhosis. So it is a progressive cholestatic liver disease, is very important, more commonly seen in middle-aged women. So pathophysiology, you have any genetic susceptible patients along with environmental and trigger factors, and with AMA positive, antimicrobial antibody positive, LFTs can be normal. So if the genetic factors are susceptible, then early disease you can see with AMA positive and abnormal LFTs. Still the genetic factors are significant, then the patient may progress to cirrhosis, or here if you don't treat early, then the patient may progress to cirrhosis or grade 3, that is fibrosis. Then liver decompensation, ultimately death. Liver transplantation is the only mode of treatment. Symptoms, which is the most common symptom, is fatigue. Patient presents with fatigue. Fatigue is the most common symptom in the case of PBC. Patient may have pruritus due to stress. Hyperpigmentation is seen. Hepatomegaly, splenomegaly, xanthelismas, jaundice, right upper quadrant pain. All these are the more common symptoms of PBC. So what are the diseases associated with PBC? You have keratoconjunctivitis sicca, that is Sjogren's syndrome, which is seen in 70 to 100% of the patients. RTA, renal tubular acidosis, is seen in 50 to 60%. Arthritis or arthropathy, gallstones, autoimmune thyroiditis, PSS, and cutaneous disorders like lichen planus, discoid lupus, pemphigoid, celiac disease, hepatocellular carcinoma. All these are the which are the diseases associated with. Most common is Sjogren's syndrome and renal tubular acidosis. Okay. So diagnosis, AME antimicrobial antibody is positive for most of the patients. So LFTs, they can be abnormal. The patient mainly has elevated alkaline phosphatase, and bilirubin can be raised. It is cholestatic type, so direct will be more and indirect will be less. So enzymes usually in the normal ranges only. Most common is alkaline phosphatase elevated with direct hyperbilirubinemia. So liver biopsy is the treatment of choice. I mean, is the diagnostic modality. It is a diagnosis of choice, gold standard test you call it. So you have 4 stages. So stage 1, the inflammation is mainly confined to the portal tracts. You see, the inflammation is mainly seen in the portal tract. It's not extending outside the portal tract. In the stage 2, so it is extending to the periportal areas, not just the portal, it is extending outside also. You call periportal area. So inflammation extending to the periportal area, you call it stage 2. Stage 3, you have bridging fibrosis. See, bridging, you have this bridging fibrosis. Whenever patient has fibrosis, bridging fibrosis, you call it stage 3. Stage 4, you have nodule formation and cirrhosis. This is stage 4. Okay, so bridging fibrosis along with nodules, that is stage 4. Treatment, UDCA is the treatment of choice. You give around 13 to 15 milligrams per kg per day. So then other drugs you can give cholestyramine 3 to 4 grams, which is mainly 30 minutes before meals. So it is beneficial in most of the patients, but fat malabsorption is a side effect, and constipation can also be. Rifampicin you give around 150 to 300 milligrams twice daily, and it is hepatotoxic, that's a side effect. So UDCA is the treatment of choice, 13 to 15 milligrams per kg per day. No major toxicity reported, that's why it is beneficial. And naltrexone, it's rarely used because it's opioid and withdrawal toxicity is there. Antihistamine you can give for symptomatic patient may have pruritus, so you can give diphenhydramine or hydroxyl. So PSC, primary sclerosing cholangitis, it's another cholestatic liver disease wherein you see diffuse inflammation and fibrosis which is involving the entire biliary tree. Okay, so there is diffuse inflammation and the fibrosis which involves the entire biliary tree, and there is obliteration of the intrahepatic and the extrahepatic bile ducts which will cause biliary cirrhosis, portal hypertension and hepatic failure. Okay, so there is obliteration of the intrahepatic and extrahepatic bile ducts that will mainly cause cirrhosis, portal hypertension and hepatic failure. Mainly it's seen in young men around 25 to 40 years, whereas PBC is mostly seen in middle-aged women. What are the diseases associated with primary sclerosing cholangitis? You have ulcerative colitis, Crohn's disease, chronic pancreatitis, retroperitoneal fibrosis, Riedel's thyroiditis, immune deficiency states, Sjogren's syndrome, histiocytosis X, autoimmune pancreatitis or IgG4 associated cholangitis. So these are the diseases which are associated with PSC. Okay. So clinical features, you have intermittent jaundice, fatigue, weight loss. The patient may have right upper quadrant pain and pruritus. So these are the clinical features mainly seen. Patient may have intermittent jaundice, fatigue, and weight loss also, right upper quadrant pain and pruritus. So diagnosis, MRCP can be done. ERCP is actually the gold standard, but because of the common side effects, you can go for MRCP initially. Liver biopsy usually shows onion skin fibrosis, bile duct distortion, and there is fibrous obliteration also. So liver biopsy findings are these: onion skin fibrosis, bile duct distortion, and fibrous obliteration. Diagnostic criteria, mainly on cholangiography, that is ERCP, you see generalized bleeding and stenosis of the extrabiliary system. So this is the ERCP finding. There is absence of choledocholithiasis. So CBD gallstones should be ruled out. There should be absence of choledocholithiasis and exclusion of the bile duct cancer. These two need to be ruled out. So these two are the most important differential diagnosis of PBC, okay, or I'm sorry, PSC, primary sclerosing cholangitis, choledocholithiasis, and bile duct cancer. So PSC, this is how onion skin fibrosis looks like. On onion skin scarring, this is a patient with PSC. So cholangiogram shows this characteristic irregularity of the bile duct tree. Okay, see, it's very regular. There is stenosis in between. There is stenosis here also. So this is how a ERCP patient looks like. ERCP of a PSC looks like. Coming to hepatocellular carcinoma, it is the most common primary malignant liver tumor. It is mainly seen in men, and cirrhosis is seen in around 75 to 90% of the patients. So clinical features, you have weight loss, anorexia, and patient may have abdominal pain. There are signs of cirrhosis, hepatomegaly, right hypochondrial mass. So all these are the clinical features, and patient may have cirrhosis also. Okay. Diagnosis: alpha fetoprotein greater than 400 nanograms per ml. Normally is less than 10. So this is the diagnosis of choice. USG abdomen and pelvis will show a lesion, and you can also go dynamic CT also. Dynamic CT is also done, wherein non-contrast, here you see there is no enhancing lesion. Mainly develops in the arterial phase. Okay, in the arterial phase, the enhancing lesion develops, and the portal venous, the lesion gets, see, the arterial gets reduced and the faint lesion is seen, and it is better again seen in the delayed lesion, delayed phase. Biopsy is always the gold standard test. Okay, Child-Pugh classification and of prognosis in cirrhosis. So encephalopathy, bilirubin, albumin, prothrombin time, and ascites. So these five are the criteria used for Child-Pugh scoring. You have 1, 2, and 3 scoring. If there is no encephalopathy, bilirubin less than 3.4 and albumin less than 3.5, greater than 3.5, prothrombin time less than 4 seconds prolonged, there is no ascites, you call it as stage 1. Stage 2, you have all these mild, 3.4 to 5, 2.8 to 3.5, prolonged for 4 to 6, and there is mild ascites. So if the score is less than 7, you call it as Child-Pugh score A classification A. If it is between 7 to 9, you call it as Child-Pugh score classification B. Greater than 9, you call it C. Okay. So in that, A is decompensated. Both B and C are A is compensated cirrhosis. If it is in the B and C, it's decompensated. So hepatocellular carcinoma. Okay. So these are the treatment. So Child-Pugh score anything A. So it's usually the very early stage, single, with the lesion single and less than 2 centimeters. You measure the portal pressure. Portal pressure is normal. You just do resection. If it is increased, and if the patient has associated diseases like any diabetes, hypertension, then you can go for liver transplantation. If there are no associated diseases, then only go for liver transplantation. If there are radiofrequency ablation, you can go for that. Okay, and Then coming to intermediate stage with multinodular, there are multiple nodules with Child-Pugh score A or B. So then you go for TACE. Okay. So this trans-arterial chemoembolization. So you inject embolize in the chemical. So the target will be 20%, and it will be less than 20 months, 45 to 40 months. So advanced stage, you have portal vein invasion. Sorafenib is the monoclonal antibody usually given here. So terminal stage, just give supportive care. The Child-Pugh is scored already C. Then if there's no role of any transplantation or other drugs. You just give supportive care. Coming to pregnancy and liver, you see if the patient has any pre-existing liver diseases like viral hepatitis, gallstones, mainly presents with cholecystitis or biliary obstruction. So this is very commonly seen in pregnancy women nowadays. Uh, any pre-existing liver diseases. So you have to rule out viral hepatitis and gallstones, cholelithiasis. Acute cholestasis of pregnancy, 20% of the cases of jaundice, you see acute cholestasis of pregnancy, more commonly seen in third trimester. Mainly they present with intrauterine growth retardation with premature birth. So acute fatty liver of pregnancy is very common, mainly seen more common in twins and first pregnancy and male baby, usually seen in third trimester. Patient may present with vomiting, abdominal pain, jaundice, lactic acidosis, encephalopathy, coagulopathies, renal failure, and hypoglycemia. So this is acute fatty liver of pregnancy. Both are seen in third trimester. This is prognosis is better for acute fatty liver of pregnancy. Toxemia of pregnancy and HELP syndrome. It is mainly a variant of preeclampsia, more commonly seen in 27 to 36 weeks of pregnancy. You see anemia. There is anemia here, and fragmented red cells are more commonly seen. There is always raised SGOT and SGPT. Patient may have DIC and placental abruption. Okay. So this is the prognosis is very poor. Patient usually in HELP syndrome, patient will have low albumin, hypoalbuminemia, elevated liver enzymes. Okay, AST, LT is elevated. Okay, and they are more prone for thrombosis also. So liver function test, you mainly look for SGPT and albumin normally fall in pregnancy. So ALP levels can rise mainly due to the contribution of placental ALP. Okay, so that's why alkaline phosphatase is more commonly is elevated in pregnancy patients. That's mainly due to the placental alkaline phosphatase. Pre-existing liver disease, you have to rule out any pre-existing like viral hepatitis because cirrhosis is not usually seen, and varicose bleeding can occur if varices are present. Patient has cirrhosis, they can have present. So if the patient has Wilson disease, you have to give D-penicillamine. If the patient has autoimmune liver disease, azathioprine should be given. So autoimmune liver disease can flare up postpartum. That's why you have to be careful and do follow up and do all the investigations and continue the treatment. So unrelated liver disease like viral and drug induced hepatitis, it mainly should be ruled out. Hepatitis, always enzymes will be very much elevated. So that's why immunoglobulins and vaccination should be given to the fetus at birth. That will prevent the hepatitis B to the fetus. Okay. Gallstones are more common in pregnancy and postpartum, and they are mainly a cause of the raised ALP level. Biliary imaging with ultrasound and MRCP is mainly safe. Pregnancy-related liver diseases may more commonly occur predominantly in the third trimester, and they resolve postpartum. So maternal and fetal mortality and morbidity mainly prevented by early delivery. So you have to deliver the baby in the third trimester. Liver transplantation, most common, if they ask you what is the most common cause of which is the most common condition leading to liver transplant, is hepatitis C. Around 33% of the patients go for liver transplantation. Hepatitis B is only 4%. Okay, next common is cholestatic liver diseases. Okay, so others you have hepatocellular carcinoma, alcohol liver disease, cryptogenic, non-alcoholic steatohepatitis. So indications: acute liver failure, complications of cirrhosis like patients with cirrhosis, ascites, chronic GI blood loss due to portal gastropathy, encephalopathy, liver carcinoma, refractory varicose hemorrhage, synthetic dysfunction. All these are the complications of cirrhosis, which are the indication for liver transplantation. Liver-based metabolic conditions include alpha-1 antitrypsin deficiencies, glycogen storage diseases, primary oxalurias, tyrosinemias, and then Wilson's disease. Other systemic complications of CLD includes hepatopulmonary syndrome, portopulmonary hypertension. So all these are the indications for liver transplantation. Absolute contraindications: HIV/AIDS, active alcoholic, the patient is actively alcoholic or substance abuse. Usually, it is a contraindication. Advanced cardiac or pulmonary disease, anatomic abnormality that mainly precludes liver transplantation. Cholangiocarcinoma, extrahepatic malignancy, fulminant hepatic failure with mainly increased intracranial pressure greater than 50 mm of Hg or CPP less than 40 mm of Hg. And then hemangiocarcinoma and hemangiosarcoma, persistent non-adherence, uncontrolled sepsis. So all these are the absolute contraindications to liver transplantation. So immunosuppressive drugs, which are mainly used in liver transplantation, you have cyclosporin, tacrolimus, prednisolone, which is cytokine inhibitor, azathioprine, mycophenolate mofetil, sirolimus, OKT3, and basic slimac. Okay, so this is mainly cyclosporin, tacrolimus, mainly same, but the more important side effects are renal toxic. Both are renal toxic, so that's why it's usually not preferred. Prednisolone with azathioprine is usually given. Okay. Side effect for azathioprine is bone marrow suppression. It is also hepatotoxic. It inhibits mainly T and B cell proliferation. I'm going fast because I've already talked about these. I'm just going for revision. So medical complications in the immediate post-transplantation period, you have infections like bacterial, viral, like cytomegalovirus, Epstein-Barr virus. Fungal, you have aspergillosis, mucormycosis, candidiasis, pneumocystis xerobaca infections. Respiratory complications, you have ARDS, pneumonia, hepatopulmonary syndrome, pulmonary edema, AKI, cardiomyopathies, hemochromatosis, hypertension, myocardial ischemia, valvular heart diseases. Neurologic complications, you have CNS hemorrhage, central pontine myelinosis, ischemic events, seizures, and coagulopathies, you have DIC, thrombocytopenia, and diabetes mellitus. So we have bacterial infections, HSV stomatitis, mucocutaneous candidiasis. So these three are mainly seen in the initial stages. Then you have CMV hepatitis, Epstein-Barr virus, adenovirus infections, pneumocystitis, xerobaca infections, aspergillus or mucormycosis. Recurrent hepatitis could be B or C. Histopathology of acute cellular rejection of liver graft shows lymphocytic and plasma cell infiltrate that will mainly spill over the periportal hepatitis. This hepatocyte is mainly seen in the periportal areas, and the central vein will show attachment of lymphocyte to the endo. We call it endothelitis. Okay. Thank you.